Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 394 of our pharmacotherapy series, which majors in seizure disorders. The next clinical case reads, PZO, a 26-year-old woman, experiences complex partial and secondarily generalized tonic-clonic seizures. She is taking phenytoin 400 mg per day and valproix 2000 mg per day. She reports having 2 or 3 partial seizures and 1 generalized seizure every 3 to 4 months. Despite taking low overall, containing norgestrel 0.3 mg with ethynylest radiol 30 micrograms, she has just learned she is pregnant. Her last menstrual period was 6 weeks ago. So my question to you is, what is the relationship between PZO's apparent contraceptive failure and her anti-epileptic drug therapy? There have been several reports of reduced efficacy of oral contraceptives in patients receiving various anti-epileptic drugs. These reports describe both breakthrough bleeding and pregnancy. Phenobarbital, phenytoin, carbamazepine, oxcarbazepine, eslicarbazepam, perampanel, and felbamate have been shown to increase the metabolism of ethynylest radiol and progestogens. This effect is not associated with valproate, lamotrigine, gabapentin, tiagabane, zonisamide, levetiracetam, lacosamide, or pregabalin. Topiramate in polytherapy and at high dosages, that is 200 to 800 mg per day, appears to have a mild, though measurable, effect on oral contraceptive pharmacokinetics. Apparent clearance of the estrogen component of combined oral contraceptives is increased in patients taking topiramate. In contrast, topiramate monotherapy in lower dosages, that is 50 to 200 mg per day, has a lesser impact on the pharmacokinetics of the oral contraceptive. A lack of contraceptive efficacy may present as irregular or breakthrough menstrual bleeding. Decreased efficacy is not always associated with breakthrough bleeding, however. Oral contraceptive doses can be increased to compensate for the effect of an anti-epileptic drug. However, estrogens also may exacerbate seizures in some women. Women older than 35 years of age and those who smoke must consider the risk of thromboembolic complications associated with higher doses of contraceptives. A second contraceptive method, e.g., condoms, intrauterine devices, or spermicide, is recommended to avoid contraceptive failure. Tubal ligation is also an alternative. An additional alternative that could be considered is injectable depot medroxyprogesterone acetate. Although there is a lack of clinical studies substantiating its effectiveness in patients on enzyme-inducing anti-epileptic drug, the pharmacokinetic characteristics of this agent suggest that its effect is not reduced by enzyme induction. Medroxyprogesterone is a high-clearance drug. Its clearance is directly dependent on hepatic blood flow. Thus, enzyme induction would have little effect on the metabolism of this drug when it is administered by injection. Depot medroxyprogesterone acetate may, however, have other negative effects that would limit its choice as an alternative contraceptive in this situation. Assuming PZO was taking her contraceptive pills on a regular basis, it is possible that her enzyme-inducing anti-epileptic drug, that is phenytoin, is responsible for their failure. Patients receiving enzyme-inducing anti-epileptic drug should be prospectively informed that this interaction can occur and advised concerning the use of alternative contraceptives. Interestingly, a different drug interaction exists between oral contraceptives and lamotrigine. The estrogen component in oral contraceptives increases the clearance of lamotrigine. Lamotrigine clearance may increase twofold when contraceptive steroids are begun and fall by 50% when contraceptive steroids are discontinued. Changes in lamotrigine levels associated with initiation and discontinuation of contraceptive steroids can result in increased seizure activity in some patients and toxicity in others. My next question to you reads: what are the risks of teratogenic effects from PZO's medications? What steps might be taken to minimize these risks? PZO's child is at risk of congenital malformations because of exposure to several potentially teratogenic drugs: estrogen-progestin combination oral contraceptives, valproate, and phenytoin. Many anti-epileptic drugs have teratogenic effects. Animal data regarding the teratogenic potential of the new anti-epileptic drugs are encouraging, but conclusions regarding the teratogenic potential of these anti-epileptic drugs cannot be made because of limited experience in pregnant women. A good resource for clinicians to educate women is the American Epilepsy Society and the American Academy of Neurology series of 3 practice parameter updates on management issues for women with epilepsy focused on pregnancy. They deal with obstetric complications and change in seizure frequency, teratogenesis and perinatal outcomes, and vitamin K, folic acid, blood levels, and breastfeeding. The authors evaluated the available evidence based on a structured literature review and provide recommendations. Most anti-epileptic drugs are believed to exert their teratogenic effects, and possibly other adverse effects such as hepatotoxicity, partly via reactive epoxide metabolites. Enhancement of the formation of these metabolites via hepatic enzyme induction, e.g., by carbamazepine or phenobarbital, or inhibition of their breakdown, e.g., through inhibition of epoxide hydrolase by valproate, would increase the risk of teratogenicity. Combined administration of enzyme inducers and valproate, specifically the combination of carbamazepine, phenobarbital, and valproate with or without phenytoin, is associated with an especially high risk of teratogenicity. In addition, each of the present major anti-epileptic drugs has been associated with congenital malformations when administered alone. Meader et al. provide data from 333 pregnancies in women with epilepsy taking an anti-epileptic drug in monotherapy and enrolled in the neurodevelopmental effects of anti-epileptic drugs, abbreviated as NEAD, study. Serious adverse outcomes, major malformations and fetal death, were significantly more likely to occur with exposure to valproate, 20.3%, than with carbamazepine, 8.2%, phenytoin, 10.7%, or lamotrigine, 1%. In addition to physical malformations, anti-epileptic drug exposure in utero has an adverse effect on neurodevelopment. The NEAD study evaluated age 6I. Q and found that valproate-exposed children had significantly lower scores, that is a mean of 97, even after controlling for the mother's IQ and seizure type. The age 6I Q scores were significantly lower for children exposed in utero to valproate compared with scores of children exposed to carbamazepine, a mean of 105, phenytoin, a mean of 108, and lamotrigine, a mean of 108, monotherapy. A European task force of epilepsy experts recommends that, where possible, valproate should be avoided in women of childbearing potential. Several strategies can be used to reduce the potential adverse effects of anti-epileptic drugs on pregnancy outcomes. If feasible, before conception, seizure control should be optimized using the anti-epileptic drug of first choice for the prospective mother's seizure type or epilepsy syndrome. Monotherapy at the lowest effective dose is the goal. Maintenance of adequate folic acid stores before conception and during fetal organogenesis is also important. Folic acid supplementation can reduce the risk of congenital neural tube malformations in infants at risk who are born to women without epilepsy, but folate supplementation does not reliably reduce the teratogenic effects of anti-epileptic drug. Nevertheless, supplementation of folic acid, and ensuring adequate folate levels, is recommended. Because about half of pregnancies are unplanned and not evident until weeks after conception, folate supplementation should be given routinely to women of childbearing age with epilepsy. No study has been conducted to determine the optimal dose of folic acid supplementation in patients taking anti-epileptic drugs. Clinicians engage in much discussion of this topic, but the current practices are not evidence-based. Even though this is the case, PZO should start taking 4 mg of folic acid supplementation each day. Physiologic changes in pregnant women may affect the pharmacokinetics of anti-epileptic drugs. Absorption can be influenced by nausea and vomiting. Hepatic metabolism and renal function both increase during pregnancy. The binding capacity of albumin is decreased during pregnancy, resulting in decreased protein binding for highly bound drugs. Unbound fractions of phenobarbital, phenytoin, and valproate increase with decreased concentrations of albumin. For drugs predominantly metabolized by the liver with a restrictive clearance, e.g., carbamazepine and valproate, decreased protein binding without changes in intrinsic clearance should result in a decrease in total drug concentrations. Unbound drug concentrations usually remain unchanged. For drugs with both increased hepatic metabolism and decreased protein binding, e.g., phenytoin and phenobarbital, both total and unbound plasma concentrations decrease, but not necessarily proportionately. The clearance of lamotrigine increases as pregnancy progresses, presumably related to the impact of estrogen on lamotrigine metabolism. This alteration in clearance changes immediately postpartum. Preliminary data suggest that oxcarbazepine concentrations may also decrease as pregnancy progresses. The effects of changes in renal function during pregnancy on antiepileptic drug concentrations are not well known. Renal blood flow and glomerular filtration rate increase during pregnancy. Thus, the renal clearance of drugs that are predominantly excreted through the kidneys, such as gabapentin, levetiracetam, and pregabalin, may increase during pregnancy. During pregnancy, serum levels of antiepileptic drugs, including free serum levels for highly protein-bound drugs, can be monitored. In this case, a pre-pregnancy level would be optimal for comparison. Dosage adjustments may help to prevent the increase in seizure frequency that is seen in approximately 25% of pregnant women with epilepsy. Because falls and anoxia associated with uncontrolled generalized tonic-clonic seizures may increase the risk to the unborn baby, PZO should be educated on the value of adherence to her anti-epileptic drug regimen. For PZO, it can be presumed that significant exposure of the fetus to any teratogenic influence of anti-epileptic drug has already occurred. Optimization of seizure control is now the primary concern for her. Any major alterations in PZO's anti-epileptic drug regimen should be made cautiously to avoid precipitating seizures. We will now briefly talk about vitamin K supplementation. Babies born to women with epilepsy who are taking enzyme-inducing anti-epileptic drug are at risk of hemorrhage owing to decreased vitamin K-dependent clotting factors. Although some question the evidence, women taking carbamazepine, phenobarbital, primidone, or phenytoin should receive vitamin K 10 mg orally every day from 36 weeks of gestation until delivery, and babies should also receive vitamin K 1 mg IM at birth. Next we will look at breastfeeding. In a lactating woman who is taking medications, the risk of drug exposure to the infant needs to be weighed against the benefits of breastfeeding. All drugs transfer into milk to some extent. The extent of protein binding of the drug is the most important predictor of drug passage into milk. For the anti-epileptic drugs, a large intersubject variability in the milk-to-plasma ratio exists, presumably owing to a difference in volume and composition of the milk. Thus, the milk-to-plasma ratio is not useful for predicting infant anti-epileptic drug exposure. Reviews on anti-epileptic drug and breastfeeding are available. For most first-generation anti-epileptic drugs, e.g. carbamazepine, phenytoin, or valproic acid, breastfeeding results in negligible anti-epileptic drug plasma concentrations in the infants. For the newer anti-epileptic drugs, breastfeeding should be done cautiously and the infant should be monitored for excess anti-epileptic drug plasma concentrations and toxicity, if possible. This information should be presented to PZO in an appropriate manner. Once she delivers her baby, re-evaluation and optimization of PZO's anti-epileptic drug therapy should occur. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 395.